Hi, this is Kip Poe. Welcome to the Texas A&M University School of Law Health Law class on quality, risk, and liability in the healthcare arena. We're going to start today in this first module by talking about the physician-patient relationship. It forms the basis of all the fundamental elements that is at play in our healthcare delivery system today. We have moved away from people having a personal private physician that they have for most of their lives to a very complex healthcare system where patients are treated by a multitude of individuals in the healthcare system, including physicians and nurses and laboratory technicians and technologists and counselors that form a team. But it all began with the physician-patient relationship. In a time where physicians often made house calls, that people had their physician throughout most of their lifetime. The same physician that treated you as a child may deliver your babies and also treat your grandparents. And it's during that time in American healthcare that the fundamental basis of the healthcare system and the duties that flow from the relationship between the physician and the patient were formed. So they're very important for us to understand that, to know before we get to the piece in this class on standard of care, potential liability, risks, quality issues, and so forth. This all began with what we call the no duty rule. One of the landmark cases was Hurley versus Eddingfield. I believe this was an Indiana case. Early on, you can see it was in 1901. Again, back during the days of physicians making house calls and being, sort of the one-stop shop for healthcare in the community. The court reasoned that, and this is about the same time that states started licensing physicians as healthcare professionals. And so there was an argument that the physician must treat patients, all patients that were perhaps in that community. But in this particular case, the court reasoned that the physician's traditional freedom to select patients remained unaltered by the advent of state licensure laws, which imposed no obligation on a physician to practice at all or on other terms than he may choose to accept. So the basis of that no duty rule is that the physician-patient relationship is a voluntary and contractual relationship. Now, we all know, none of us have probably ever been to a physician's office or to a hospital where we actually had to sign what we would consider in the legal field as an actual contract, where the physician agrees that they will provide care for a certain period of time, and the patient agrees to do certain things such as pay the physician or at least provide for or arrange for some type of payment. So in absence of that type of contract, the physician really can pick and choose who they're going to treat. So when a physician decides, I am going to treat this patient, there's an implied contract from that point on that the physician is voluntarily agreeing to treat the patient and that the patient will voluntarily agree to do such things. There's several caveats to this voluntary agreement, however. One is when perhaps a new patient were to phone into a physician's office and say, hey, you're accepting new patients. I would like to make an appointment to see, the physician. The office staff makes the patient an appointment. The patient travels to the doctor's office, sits in the waiting room, maybe fills out some paperwork, hasn't seen the physician yet. Maybe the physician looks out and goes, oh, I didn't know that patient was coming. Either I've decided I'm not taking new patients, or I know that patient from one of my colleagues, and that's a very non-compliant, difficult patient. I don't want to take that patient on. So in that scenario where the patient has an appointment sitting in the physician's office, is there an obligation for the physician to treat that patient? Well, the physician may argue, I haven't accepted that patient. I haven't seen them. But there's a strong argument on the patient side that I called the physician's office. His office staff is acting on the physician's behalf and is an extension of the physician and made me an appointment. I relied on that. I've taken off work, I'm coming to the office, and I'm sitting here expecting to be seen by the physician. And if I'm not seen, I could allege that there's a delay in care, and now I've got to spend more time looking for another physician while my condition gets worse. So it would be a risk for the physician in that situation to say that they haven't established the physician-patient relationship, but that may be dependent on different jurisdictions as to how the outcome of that type of case may come out. Another area that is a caveat to the physician-patient voluntary relationship is with consults. If let's say an emergency room physician says, I think this is a surgical case, and I'm going to formally consult one of my surgery colleagues or whoever the on-call surgeon is in the hospital. They come down, the surgeon comes down, sees the patient, does a formal consult, decides this is not a surgery case. Well, the surgeon has agreed to come and see that patient, provide a consult, and they do have a physician-patient duty. It may not extend beyond that consult because they've decided, there's not a surgical issue. But if they were negligent in determining whether there's a surgical issue or not, they would have had a duty to that patient to make that determination according to the standard of care. That's opposed to what we often call in the healthcare field a curbside consult. A physician calls up a colleague or sees them in the hallway and says, hey, I've got this patient, here's their signs and symptoms. I don't know what to do about that. Have you ever seen that before? What advice would you give me? In that situation where the curbside, if you will, consult, the physician that's being asked to ask questions, they're not formally agreeing to see the patient. They're not looking to get paid for that time. They're really just providing a service to another colleague. Most jurisdictions would say that the physician-patient relationship is not begun in that type of situation, and there's no duty between the physician and the patient in that situation. There are a few jurisdictions who may find a duty in that type of circumstance, but generally it's going to be no, that's not enough to actually initiate the duty rule. Another situation is when the exam of a patient comes at the request of a third party. For example, a new hire in an employment setting, and the employer says, you're going to have to go have an initial physical exam to make sure that you are physically capable of performing this job. Well, the physician in that situation is hired by the employer for a specific purpose of doing a pre-employment fitness exam. Well, the employee or the patient in that situation is not hiring the physician, is not saying, I want you to be my physician. This is for a very limited purpose. Most jurisdictions in that scenario would say, well, there's not a physician-patient relationship form there. I mean, the physician doesn't have any obligation to provide ongoing care to the patient, to provide follow-up care to the patient. But many jurisdictions would hold the physician to the standard of, if there's something that you find that another reasonable physician would find in the course of that very limited examination that the patient or a reasonable patient would want to know about, you should provide that information to the patient. So let's say the physician did some blood work and the white blood cell count came back extremely high. Well, that would be something that the physician wouldn't have a duty to follow up on with the patient, wouldn't need to bring the patient back in and start treating them for potential infection or anything like that, but would have a responsibility perhaps to notify the patient there was an abnormal lab finding, the labs found that you had a very high white blood cell count. You need to follow up on that with your physician or with a physician. There are some jurisdictions that would hold the physician to that type duty. Other jurisdictions may say, no, we don't think that's enough. This was a very limited time that the physician was asked to do a very small thing with the patient. But most people just under, the ethical principles would say, if you find something that could be harmful to the patient, you really need to notify them of that. The final situation that brings some nuances to the physician-patient relationship is managed care networks. Many people now in the United States are under some type of managed care network, either through their employer, through Medicare, Medicaid managed care networks. And those networks often are formed with provider groups, and like a group of providers or hospitals may say, we want to be in your network. And part of the network agreement is that the physician or the hospital provider, whoever it might be, agrees that they will take all the subscribers or the members, the patient members in that network. And in that situation, there may be an obligation by a physician to treat someone just because they're in a network that the physician has wanted to be and agreed to be a part of, even though the physician has not seen that patient or agreed to see that patient before. So managed care is really bringing a lot of nuances to the traditional physician-patient relationship role. Even though it may be a voluntary and a contractual, albeit an implied contract, but a voluntary and contractual relationship, once the relationship is established, i.e. once the physician says, yes, I will take you on as a patient, then the physician has ongoing legal obligations to treat that patient. Now, that obligation and the ongoing expectation is quite often related to the scope or the expectations. Again, let's look at another example. Let's say that you have a surgeon who agrees to treat a patient who has appendicitis. So the surgeon brings the patient in, examines them, does surgery for the appendicitis, does follow-up until they say, okay, your appendix is out, your infection is completely cleared, our relationship is over, essentially. You don't need to come back and follow up with me. Then that relationship is over for that particular interval of care. And if the patient had something else come up and they needed their gallbladder out, the physician would be able to say, no, I don't have time to take on gallbladder cases, or that's outside my scope. They don't have to take that patient on. It's episodic based on the type of care that's needed. So as long as the episode of care is no longer ongoing, then in that episodic type care, then there would not be an ongoing requirement for the physician to see that patient. Unless, again, sort of the caveat, one of those managed care situations or another exception would come into place. That is opposed to a primary care physician. Most networks, most of the healthcare in the United States is now delivered under a care system where at least the intent is for a patient to have a primary care physician. And that is a physician, usually a family medicine provider or an internist or a pediatrician that agrees to take that patient on into their practice. They generally see them yearly, do well check examinations, follow chronic diseases, do necessary yearly recommended lab tests, that sort of thing. In that type situation, that obligation will be ongoing until it's otherwise terminated. And we'll talk about how sometimes, those relationships are terminated or the physician formally terminates that care. So and another area where it can be limited is if a patient consults a physician and what the patient needs is outside of that physician's scope. So they're going to a family practice provider and say, I need care for my broken femur, my broken leg. The family practice physician may say, I don't do that. You need to go to an orthopedic surgeon. In that situation, the family practice provider wouldn't have a duty to take care of the fractured leg, but they would have a duty to refer the patient to a provider who was qualified to treat that condition. But the family practice provider may still have an ongoing obligation to the patient to follow up, to make sure that they're getting that leg taken care of, and then to take care of their other healthcare issues during that period of time. The physician-patient relationship and the physician's obligations are not dependent on the patient's payment. So while a patient may say and may have an obligation to provide payment, if they stop paying or whatever payment they arrange for their insurance, for example, let's say they lose it and the insurance payments stop coming in. Well, the physician still has an obligation until they properly terminate care. And again, we'll talk about terminating care and what's required for that in a few minutes, but it's not solely based on the patient continuing to pay. So if a physician is treating a patient and they don't pay for one visit, the doctor can't say, I'm done. I'm not going to follow up with you and do the needed lab work and so forth you need to do. that is not acceptable. There is an ongoing relationship there until it is properly terminated. The physician-patient relationship is fiduciary in nature. It's founded on the patient's trust and confidence in the physician's integrity, knowledge, skill. In essence, the physician has advanced knowledge. They've gone to medical school, have a higher level of training, knowledge, and skill to treat the patient's healthcare conditions that the patient doesn't have. So there's not an even bargaining power. The physician is much more qualified than the patient. The patient needs the expertise that the physician has to offer. So it is based on the physician's integrity, loyalty to the patient, and fidelity to provide care to the patient according to the recognized standard of care. And so it's not an arm's length relationship by any means. The patient is dependent on that physician's significant level of knowledge and skill to treat them. I think it's very important to understand the basis of that physician-patient relationship as a fiduciary relationship being at the core of medical practice and something that's taught to physicians. I think most physicians take that relationship very seriously. And to give you a look into that, I want you we'll stop this video here in just a second and give you an opportunity to look at a YouTube video by Dr. Abraham Verghese. Dr. Verghese is an internal medicine physician. He specializes in infectious diseases. I had the opportunity to know Dr. Verghese when I was teaching in the general counsel's office at Texas Tech University Health Sciences Center, and he was there too. He's now at Stanford University, but he is a very well-known physician, has expertise in many areas, but one of them being the physician-patient fiduciary relationship and just that bond that should develop and hopefully does develop between physicians and patients. So I'll give you an opportunity to please review that video with Dr. Abraham Verghese, and then we'll come back with a new video to continue on with the physician-patient relationship and duties.